Good evening, I'm Mike Knetter, and welcome to the UW Now Livestream series, where we bring you experts from the UW community talking about timely and important topics. I think we've hit the mark tonight. There may be an unwanted guest at our holiday table, the Omicron variant. Many questions hang over the world as the variant cuts across the globe. How does its transmissibility and severity compare to the Delta or Alpha variants? How well do vaccines and treatments work to reduce transmission or severity of the new variant? Can we avoid travel bans, school closings, and lockdowns? Can the hospital system withstand the potential surge in patients? And whatever happened to herd immunity? Is that still relevant, or is the pandemic becoming an endemic? We will hear tonight from Dr. Nasia Safdar, who's with us for her 5th UW Now appearance. She is our, I would just say, official COVID expert. Dr. Safdar is a faculty member in the Division of Infectious Disease, the Vice Chair for Research in the Department of Medicine, and the Medical Director of Infection Control at UW Hospital and Clinics. She was recently named the School of Medicine and Public Health's inaugural Associate Dean for Clinical Trials. She leads the Department of Medicine in its mission to reduce healthcare-associated infections by identifying, testing, and implementing novel interventions. Dr. Safdar has received a President's Early Career Award for scientists and engineers, the highest honor bestowed by the U.S. government on outstanding scientists and engineers beginning their independent careers. She's also received a John Q. Sherman Award for excellent in patient engagement, and she's a fellow of the American College of Physicians and a member of the Society of Internal General Medicine. Dr. Safdar, I know it is still a really busy time for you, probably 22 months into what I'm sure has been one of the biggest professional grinds of your lifetime. I hope that we can see a light at the end of this tunnel, but I sure appreciate, and I know our audience appreciates, you coming on to share what you've learned and what you're seeing and what you see ahead. So please share with us your update.
Sounds great. Thanks very much, Mike. I'm going to share my slides here. Okay, I'm assuming you can see this okay. So thank you for the opportunity to speak today about the Omicron variant, this little slip of a virus that has really led us to rethink everything about our lives ever since the pandemic began. So of course, there have been other variants before Omicron. Actually, before I keep going, let me just check and make sure. Can you hear me okay? Okay, great. All right, just wanted to make sure since that has happened before. Okay, so let's go back to talking about the Omicron variant. Now, there have been, of course, other variants before this, including Delta, which was the predominant one before this one sort of came out of nowhere and swept everything else away. But the reason that the Omicron variant was identified as a variant of concern by some very astute scientists in South Africa, who noted that among the characteristics that it shared, which rendered it very dangerous in terms of its spread, was that it had a lot more additional mutations than the other variants had, and most of them were centered around this receptor binding domain, or the spike protein. And the spike protein is, of course, what most of the vaccine immunity is generated against. It's the area where the virus will bind to the host receptor, and if there's any variations in its ability to bind, typically it favors the virus, which is that it binds more tightly or evades the immune system such that it's not even recognized as having bound until it's already done. So it can really function very much like a stealth burglar. And that was the concern with Omicron. So if you look at this last one here, just the sheer number of mutations is astonishing. And I don't think we quite know how it happened the way that it did, but suffice it to say that it did not make its presence stay subtle for long. And within a matter of days since the first day that it was detected, it really was then found in numerous other countries around the globe, including the US. So, of course, this is still very early days for Omicron, and there's lots of things that we don't know. But I thought this would be helpful to share because one of the earlier concerns was, is it going to cause the same syndrome, the same spectrum of disease, or are there additional or novel or different symptoms that one should expect from this? And this was somewhat encouraging. This is only about 43 or so patients. You can see that most of them were symptomatic, which is to be expected, which is how they had the testing done. And these were mainly because these were early cases, they were largely travel associated. And of course, people who travel tend to be relatively mobile and healthy and so on. So, having taken those caveats into consideration, the major symptoms that people were reporting was cough, fatigue, and congestion or runny nose. And if you take the cough out of the picture, who isn't fatigued these days? So then you're left with congestion or runny nose, which people might interpret to think that it's maybe their allergies or it's the common cold or it could be something other than COVID, which all of that is true. But you also cannot distinguish COVID from other viruses just by virtue of symptomatology alone. And so that's really the triad for Omicron, which is also the case for other variants. The other symptoms have been also reported here, and I think that as the case count grows, we'll probably see the full spectrum of symptoms that we have come to expect COVID to produce. As far as we know at this point, so the symptoms appear to be similar to Delta and other variants. The disease spectrum overall, I think possibly a reason for optimism in the sense that it doesn't appear to be any more severe than Delta. But I think it still is very much early days. And I think we will have to see whether the South African experience, which is that they had this huge wave, the symptoms were relatively mild, but nonetheless, the numbers were astonishing. And now they're on the downswing. And we'll have to see if that experience is replicated in the US. Many people feel that it won't exactly be because for us in the US, given the sheer geographic size of the country, is that it has always been a regional rolling pandemic and you have hot spots and then those come down and other ones rise up, such that there's never really any kind of respite than one can expect. What we do know, I think, pretty clearly is that it seems to be more transmissible than Delta, which probably has a lot to do with its mutations that has conferred upon it the ability to be very contagious and move from person to person with great ease. And that, I think, is behind these understandable decisions that people have made about reinstituting lockdowns and moving classes back to virtual and so on. I think it's definitely novel, it's scary, it's concerning. But we also have to realize that this is just the way viruses behave, and this mutation is not entirely unexpected. It's just that it's more concerning than one would, of course, have liked it, any kind of mutation to be. The problem is that even if the disease is no more severe, just the sheer volume of people that might need to seek medical care is very likely to push health systems to the brink. And in Wisconsin, we're literally already there, and Omicron has just arrived here. It's already likely to become the dominant variant very soon, just like it has in the US. So it's really just a matter of days given the doubling time of this virus. But a small fraction of a large number is still a very large number. So I think health systems are bracing themselves for there's the usual high volume of patients who need care who don't have COVID. Then you add to that patients with COVID. And in addition, you add all the other respiratory viruses, including influenza, which is on the upswing as well. And that is a recipe really for a perfect storm of a winter season. The other concern that has been raised is that if this virus has all these mutations, does it make it more likely to escape the immunity that might be conferred upon an individual by prior infection? Historically, we have been somewhat reassured that if someone has had SARS-CoV-2, then they're much less likely to get reinfected. And I don't know that we can quite say that to be the case of the Omicron variant, although it's still, again, pretty early days. And the way that people measure reinfection is really just clinically. So if someone has had a symptomatic infection and they test positive for SARS-CoV-2, and 90 days later they have a similar respiratory syndrome and they test positive, that's considered a reinfection. But really the only way that you can know if someone has had reinfection is to do genomic sequencing of the virus to show that what happened next was different from what had happened before. And most of the studies have not had the capability of doing that, including this one. So this was a pretty broad strokes, 90 days after the first infection, if you tested positive for SARS-CoV-2, then you were considered to have a reinfection. And of course, all of this is dependent upon people getting testing. And with Omicron now rising, the threshold for getting tested is lower. People are desperate to get tested. In fact, in countries where this has really been a huge problem thus far and is expected to be here as well. And so as you test more, you're likely to find more positive cases, some of which will undoubtedly be reinfections. The good news, though, is that, which I think in part explains why it might be no more severe than and potentially less severe than Delta, is that if you look at this slide, so just a disclaimer that this is a preprint, as are most of the things I'll be referring to today, because there just hasn't been time for papers to get through peer review. But I think that what we noticed in this study, which was interesting, is the way that the Omicron variant affects or infects the human respiratory tract. So here in this slide, you have the bronchus, which is just the tubes leading into the lung, and then you have the lung itself. So while you can see that Omicron is here in blue, so compared to the original SARS-CoV-2 and compared to Delta, the Omicron replication in the bronchus was several fold, 70 times higher than Delta, which I think explains this concern about the very ease with which it's transmitted from person to person. But on the upside, the replication in the lung for Omicron was much less than it is for the other variants. And that might speak to the fact that this is the reason why we might expect to see lower disease severity. Ultimately, I think if we are left with a variant that no doubt infects a lot more people than one would like, but doesn't cause the dreaded COVID pneumonia or the need to be on a ventilator or the need to be short of breath, then that is a silver lining with this variant, if that holds to be true as we see more cases arise. Now, this is how fast things can happen. We were just swimming along with Delta for a long time here. And then in a very short period of time, you can see that Omicron, which is in purple here, really took off. And it's now accounting for 73% of the cases that are being reported nationwide. And I think within a very short period of time, maybe just days, it will likely be the dominant variant, even more so, accounting for 90% or higher of cases. There's really not much else that is expected to supplant this until or unless another variant comes around. Our genomic capability or sequencing capability in the US has historically lagged behind other countries, but there's been a lot of investment made in this infrastructure. And so even though we are now looking very closely and more aggressively and more carefully, there still is a lag between when samples are submitted and when sequencing is done. So whatever you see may well be out of date by the time tomorrow rolls around. It's also important to remember that a conventional test, such as what we get, which is a nasal or a nasopharyngeal swab, can only tell you if you have SARS-CoV-2 or not. It really can't tell you what kind of variant you have, because you have to have special sequencing techniques for that. And while Delta was around, we didn't really care as much because we knew that most of what was circulating was Delta. Now, of course, that's changed. This is the Wisconsin SARS-CoV-2 genomic dashboard. You can see that for a long time there, Delta was the predominant variant. It may still be for a few days, but Omicron is rapidly catching up. And again, this data lags behind. So by the time everything is said and done, it is highly likely that we will be in the same position as the rest of the country. Now, we know that the experience of people who have been vaccinated differs vastly from the experience of people who have not been vaccinated when it comes to contracting SARS-CoV-2. And we know that wonderful as these vaccines are, they don't entirely prevent COVID-19 cases. But I think we would all be okay with the fact that even if we were to get COVID-19 following vaccination, if it's a mild disease that allows us to return to normal after a few days of admittedly, not feeling great, but it's a far cry from needing the ventilator or being in the hospital or in the ICU. And this you can see here. Over the course of time, you can see what the rates of COVID-19 cases are by vaccination status. This is for the US. You can see the unvaccinated is the black bar here, or line. The blue is the fully vaccinated. And this is the incidence of COVID per 100,000 population. So much, much lower in the group that is fully vaccinated compared to the group that is not. And fully vaccinated here was really defined as 2 doses of an mRNA vaccine or a single dose of the J&J vaccine. And so in October, unvaccinated persons has 5 times the risk of testing positive for COVID-19. But it's not just the testing positive, it is also the risk of death, which is dramatically different in people who have been vaccinated and is dramatically lower in that group. And that's really the whole purpose of the vaccines. The primary outcome of interest for all the vaccine trials was complications of COVID, such as hospitalization and death. It would, of course, been wonderful if it had completely prevented all kinds of breakthrough infections. But I think we know that not only is not the case, But with Omicron, we're actually likely to see more breakthrough infections. But again, if they don't translate into anything worse than that, it might still be acceptable. And so both deaths and the cases are much, much lower in the group that's been vaccinated. So that was, before Omicron, and that was before we realized that there was a decline in the level of antibody response to the vaccine, and when booster doses rolled around. And Israel was the first to note that there was this decline in vaccine effectiveness over time, such that a booster dose might become necessary. So this paper talks about the Israel experience and the effect of the booster. So again, this is all, pre-Omicron, but I think the lessons from history can really inform us as we go forward in figuring out how to deal with Omicron. And so in this slide, you can see that this is follow-up period over days, and this is the hazard ratio for death. So the higher it is, the higher the likelihood of dying. And you can see that in people who did not get the booster, there was a much higher risk of death compared to people that did get the booster. And that has prompted Israel to really mount a huge campaign to deliver the booster of all types of vaccines to its population. And I believe that today there was an announcement that they're thinking about a potential fourth dose as well, which is not the case in the US at the moment. It's still the one booster that's recommended. So how does that feature with Omicron then, and what can we expect as far as vaccine response? So there are two ways that you can assess vaccine response in SARS-CoV-2, which we're talking about in this case. One is that you can do a blood test to measure the level of neutralizing antibodies. And the way that this is done is that you take a population of people who have been vaccinated, you take blood from that population, and you apply it to the variant of interest, whatever that might be, Omicron in this case, and you see whether the neutralizing antibodies can effectively neutralize this variant. And so here, what people have found, again, these are mostly preprints, but they have found that without a booster, Omicron has the ability to evade the immune system pretty remarkably. But with the booster of, in this case, this is the mRNA 1273, which is the Moderna vaccine, it reduces the ability of Omicron to escape from these neutralizing antibodies. And that is very good news because it suggests that, just as people have been saying, including the CDC and others, that you should really get the booster. People should think of that as not just something that's good to have, but a must do at this point. You're not done with vaccinations until you've had your booster. But when all is said and done, neutralizing antibodies is great, but that's really not the outcome of interest. What we're most interested in, how does that translate into vaccine effectiveness in the form of COVID-19 syndrome and symptoms in people and complications thereof? And so this was a study that took it a little bit further, and they looked at the effectiveness of COVID-19 vaccines against this Omicron in particular. And what they found was here, so they looked at two different vaccines. So on the left-hand side, that's the AstraZeneca vaccine, which is not approved for use in the US, but is widely used around the world. And they paired that with a Pfizer booster dose. And on the right-hand side of the slide, you can see that there were two doses of Pfizer paired with a booster dose. And so if you just look at dose 2, you can see that the level of vaccine effectiveness, so this was symptomatic disease, it's not just the blood test, it's actually symptoms in people. And you can see that over time, the level dropped pretty dramatically in terms of vaccine effectiveness with just the dose 2. But when you have the booster, then you can see that vaccine effectiveness rises very high, actually, and to a level where one can expect pretty reasonable protection against it. So Delta here is the black squares, and the other one is Omicron, and you can see that that's true for both Delta and that's true for Omicron, that vaccine effectiveness rises with the booster. I think this is really good evidence for us all to think about strongly getting the booster as advised. And the same is true for if you have the 2 doses of Pfizer, the effectiveness drops over time, but not quite as low, and then it jumps up again with the booster dose. So I think this will remain our main line of defense, even while biotech companies and others try to create Omicron-specific vaccines, which may well take more time than we have. So monoclonal antibodies, as we know, have been the mainstay of treatment for patients with mild COVID-19 illness in the outpatient setting. And you can see that there is a whole array of them that are available. Typically, healthcare systems have chosen one or the other, whatever was readily available, and have used that to help prevent complications and progression of COVID-19 illness in people. So over here, you see the various variants, both in terms of neutralization and in terms of binding with the monoclonal antibodies. And you can see that with Delta, most of them work pretty well. That's not the case with Omicron. In fact, there's only a few that are expected to have reasonable activity against it. And the one that's available here, sotrovimab, is really in pretty limited supply. So in certain parts of the country where it is already clearly known that Omicron has become the dominant variant, healthcare systems have stopped using these other antibodies and have waited for sotrovimab to be available so that they could administer it. So I think that, despite the array, and these are probably already being modified and adapted to tweak them to make them more active against Omicron, which is all great, but it does leave us a little bit behind in the fight against this particular variant. One thing I'll just mention is, with all the emphasis on testing, the two main ways that one can test for COVID is, of course, there's the antigen test, and that's what we've heard a lot about in the media, and the widespread availability that the US is expected to make for that test to the population. And the other is a PCR test. So lateral flow assays, which is just another term for the antigen tests, are very good, but they do have a lot of limitations. And one of their main limitations is that they are not as sensitive as the PCR. So a negative test in someone who has symptoms should not be interpreted as saying that one doesn't have COVID. It simply probably means, especially now that we're seeing such high case counts, it probably just means that the test did not have the sensitivity to detect COVID, and it should be followed up by a PCR test, which is the gold standard and is far more sensitive than the antigen. For somebody who doesn't have symptoms and is getting an antigen test because they're going to engage in, meeting people or going to gatherings, and they want to just ensure that they are not symptomatic or that they are not going to expose anyone else, I think the use of an antigen test is a good use, just as long as people remember that a negative test simply means that at that point in time, you don't have the illness. It by no means predicts the future. So 4 days ago, if you were exposed to COVID from someone, you get an antigen test today and you're negative, that's great news, but it doesn't mean you won't get symptoms tomorrow and need to be retested. So these are really meant to be sequential tests rather than a one and done situation, which is why I think the supply of these really needs to pick up so that people can have access to them. The downside of the PCR, of course, is that it can remain positive for months after an initial illness. And it doesn't mean that one is contagious or infectious. It simply means that the virus is there, probably not alive, but the PCR isn't able to detect that. And so just something to be aware of. So, when all is said and done about Omicron, what are our ways of protecting ourselves against it? Of course, masks work against all viruses, and I think non-pharmaceutical interventions will still need to be continued, but vaccination is still going to be the mainstay of defense, particularly the booster doses, which surprisingly, a very small percent of the US population has embraced those. A larger population has eventually embraced the vaccine, but now we also need to think of the booster as just part of the series and get that done. So masks are a useful adjunct, but I just wanted to post these pictures here so that people could see the things that you all probably notice on a day-to-day basis and is very common, which is the incorrect use of masks. A mask that is not multi-layered, that does not fit well such that you're always fidgeting with it, that is either not disposable or is not frequently washed if it's reusable. And worst of all, if it's just hanging on your chin, it really isn't doing anything, of course, to protect you against the entry of any virus particles. So if you're going to wear a mask, I think it's really important now to make sure that we wear the right kind and something that's comfortable and breathable, so you're not always tempted to pull it away when you're speaking or other things that we do with masks. So I think testing is going to be a really important and a necessary strategy, and I hope that the plan that was outlined today by the administration to make tests more readily available comes to fruition, because that's going to be pretty key to this whole thing. So, what is the end game with this? There's going to be additional variants. There's going to be new things. I think the end game is to enable us all to put some mitigation measures into place on a routine basis such that we can consider ourselves to be living with endemic SARS-CoV-2. I think it's become clear that we can't eliminate it. We certainly can't eradicate it. And so what we're left with is, how can we manage it so that people can still live their lives? It might be hard to think about anything other than COVID, But there's a lot of literature now coming out about the profound ill effects of lockdowns and shutdowns and school closures on the mental, physical, and behavioral health of children. So for the next generation, I think those are measures of last resort rather than an immediate gut reaction when a variant comes around. I think in the future, there will likely be better universal next generation vaccines that won't need these boosters administered every so often, and that will tackle a wide array of all types of coronaviruses. And I think the next big thing in our armamentarium really should be to focus on therapeutics for ambulatory situations where patients aren't sick enough to require medical care, but they have symptoms, they need some intervention to help them get better quickly so that there is no progression to severe illness. And several companies have come out with potential medications. The one that's most widely known at this point is molnupiravir, which is an antiviral, is expected to work against all variants and is used within the first 5 days of symptoms for a 5-day treatment course. In the safety of your home. It's not like monoclonal antibodies where you have to go in somewhere for an infusion. So I think when this becomes approved here and it's in the process, this would really be a very welcome addition to what we have currently available. And I think, for a long time we were thinking that maybe convalescent plasma has had its day and it's gone and it really doesn't work. And all of that is true, I think, for hospitalized patients. But just very recently, there's somewhat intriguing study in outpatients came out from Johns Hopkins, which suggests that convalescent plasma, when given very early on, which is high titer, may still have a role. So I think that needs to be reviewed and the data needs to be better understood. It's not been peer reviewed yet, but there may be some more things than we had thought were there. And finally, if you're getting a sense of deja vu, you are by no means alone. Thank you for your time. Be happy to take questions.
A sense of deja vu. Dr. Safdar, first, just tell me how you're doing personally and how you feel morale is, locally and nationally among healthcare professionals.
I think healthcare professionals, as a group, have an enormous amount of resiliency. But I think, like everyone else, we have been taxed to the limit. And I think we are seeing burnout and fatigue and exhaustion. Not so much because we know that the pandemic, when we've been dealing with it for a long time, but because there's no known end to it. How long are we going to be dealing with this? No one knows. And so it's that piece, I think, that makes people feel very pessimistic at times.
My oldest daughter just started her nursing career in October. I read an article on Bloomberg today that suggested, I think it said 21% of nurses think they will leave the profession within the next year. Could we survive that kind of exodus? How are we going to keep people interested in that field?
Well, I think it's been a little bit interesting with COVID because on the one hand, just as you said, 1 in 5 healthcare workers has left what they were doing and has gone on to other things. Most of them, if you really look at the data, are at the older end of the spectrum, such that, maybe they wouldn't have retired a few years, but this has accelerated their decision to leave the workforce. So the silver tsunami of the exodus of the healthcare workforce, I think, refers to that. But on the other hand, it has generated record admissions to nursing schools, to medical schools, to pharmacy schools, because of this great desire in people, I think, to enter a very meaningful way of life. And so that's very heartening to see. But you're right, I think we'll need very novel, innovative solutions. This staffing crisis will not end in the short term.
Very practical question from Jim Poseen. Dr. Fauci suggested today that small groups of fully vaccinated and boosted individuals could safely gather indoors without masks for the holidays. Can you address what precautions are necessary for families with members too young to have had the vaccine? So if we have children present who couldn't be vaccinated, in your opinion, does that change things? And who is really at risk in that situation? Is it the older people or the children?
Yeah, that's a really good question. I think a lot of it boils down to how risk averse one is. On the one hand, having the majority of people vaccinated and boosted does offer a great deal of protection. And of course, this is a generalization, but children as a group have fared relatively well with the COVID-19 pandemic. Of course, there have been thousands of cases in children, and no discounting of that. but as a group, compared to older adults with immune compromised conditions and so on. So, but if people are really concerned about that, which many might be, you could really make use of testing strategies. So, testing children before and after would give you the answer if you're seeking, and if everyone is negative, then I think you can be reasonably comfortable in that setting without masks.
A question from Charles Herf. After 2 vaccines and a booster, what should we expect in the future? More boosters, pill treatments, other preventive measures? What do you foresee?
I think for preventive measures, I think it is likely that there may be a need for more boosters unless we have an Omicron specific, which might be in the form of a booster or might be, a completely different configuration of the vaccine. But that's, I think, just sort of short term, trying to stem the tide type of approach. Down the road, I think we'll have universal vaccines with a much broader spectrum of activity so that we don't have to, chase after every variant that looks like it's going to cause problems. I think in terms of medications that are prophylactic, our choices are pretty limited. I mean, we thought we had that with the monoclonal antibodies, and now we find that we really don't, depending upon the variant. So if by some happy coincidence, Omicron disappears and the next thing that comes around is susceptible to the monoclonal antibodies, then I think we'll have that for prevention. And there's at least 100 plus, medication agents in various pipelines for development. Of course, we know that not all of them will make it to the finish line, but it does seem promising that so many agents are being studied.
Early on in the pandemic, a lot of people talked about the concept of herd immunity. With all the variants that have developed, is herd immunity something that's just kind of out the window now? I don't hear as much discussion about it.
I think we certainly don't talk about it as much. And I think that is the case, that it's a very fluid, moving target. Earlier on, we thought that if 80% of the population could be vaccinated, that would be it. Then we said, well, kids can't get it yet, so we won't reach herd immunity until they get vaccinated. And so I think overall, it's been an evolution of what herd immunity might look like. But I think with the evasion that the virus is displaying against the vaccines without the booster, and the reinfection risk, I think herd immunity is a bit of a lost cause potentially.
So in the economics profession, there's an organization called the National Bureau of Economic Research, and they decide when something's a recession, when we're in a recovery, et cetera. Is there a body that would decide when the pandemic transitions to an endemic? What does that mean, in general, and practically speaking, what are the implications of a pandemic becoming an endemic?
So the WHO is typically, the entity that has the most weight here. I mean, they're the ones that declared this a pandemic, and so we're waiting, whenever the time comes. I think the way that things move from pandemic to endemic is if you reach this, it's never really comfortable, but if you reach this space where health systems aren't overwhelmed, we have good therapeutics, we have reasonable preventive measures, and most of the world is in the same boat. I mean, right now there are such massive disparities in vaccine availability and healthcare provision in many countries around the world that I think we are a bit away from, quite a ways away probably, from declaring this to be endemic. Locally, though, in our communities, I think in our mindset, we have come to the conclusion that, yes, this is going to be hanging around in some form, hopefully not in as terrible a form as it is now, but in some form.
And so tell me a little bit more about what that might mean for the United States and how we would operate. Are we going to begin to accept that this is like a severe version of the flu?
Well, I think we do that with the flu, right? So there's about 36,000 or so people that die every year with the flu in the US, and it's a risk that we have accepted because we know that we can't completely get rid of it and it's going to mutate every year and we need a vaccine every year for it. At the moment, of course, the toll with SARS-CoV-2 is just astronomical. But if we can get to a point where we have good treatments for it, the illness is mild in the vast majority of cases, and we can keep the health systems from getting overwhelmed, then I think that it will be much easier to deal with.
A question from Michael Benninger in our audience. There was an announcement that the CDC is retiring a type of PCR test at the end of this month. Why are they doing that, and what does it mean for the availability of testing as we go forward with Omicron and other variants?
Yeah, so I mean, the There's always going to be refinements and improvements in the type of PCRs that are being offered, and there's a wide variety of them, and they all seem to work much like the others. So I don't know the specifics of why this particular one is being retired, but it could just be an old generation that now has a better, improved model in place. I think as far as testing capability goes, we've had those scary days earlier in the pandemic when there were no tests to be had and we had to make all kinds of decisions without really any data at hand. I don't think that we are going to go back to that state. I think the supply chain is better, but it is by no means completely the way that one would like it to be. But I think today's announcement from the administration and their commitment to using all kinds of additional measures to boost testing is a step in the right direction.
Question from Chris Flink. A family member originally got the J&J shot and is now worried about the news regarding its lower efficacy than Pfizer and Moderna. He's had the booster, but wonders if he should try to get a second booster to get a full dose.
Yes, it's a good question. I mean, at the moment, we have to stick with what the CDC and the FDA has approved the vaccine usage for. And so there's the one booster that's allowable or approved at this point. I think eventually it may be the case that one would need a second, but the timing of that is not clear. I think we're already sort of different enough from other countries. So, for instance, Canada has said that the timing between the second dose and the booster can be as little as 3 months, for instance, whereas here we're still saying 6 months. So there's going to be variations, I think, from place to place. But here we do have to stick by what the FDA has authorized.
So, if I can ask, how full are the hospitals in Madison right now, hospital bed usage?
We're at capacity, and I think it's a combination of there's, of course, a large population of patients who need care that isn't related to COVID, and then there's a large population of COVID positive patients, and there's the uptick of influenza and the other respiratory viruses. So all of that together has really made it a terrible storm.
And what percentage of beds would you say are COVID patients currently?
It varies. I would say 25 to 40 or thereabouts. But this is, if this continues the way it is, this is probably just the beginning of the surge for us. And what we saw last year is that within a very short period of time, you do nothing but, it's just COVID patients filling the beds. And so I think that's what we're bracing ourselves for.
Yeah, and as I understand it, it is overwhelmingly unvaccinated individuals who are needing treatment.
That's true. The vast majority are. And I think that is what has led us all to conclude that, yes, the syndrome in somebody who's vaccinated is very different from the syndrome in somebody who isn't. And it makes sense, if you have no line of defense, how can you expect to have mild symptoms?
Yeah, the numbers are against you. I mean, still, most unvaccinated people won't have hospitalization, but the probabilities are still so much higher, as your chart showed. And do you think there's any hope that, I'll admit, I don't think we're doing a good job of sharing the information about exactly how full hospitals are, what fraction of beds are consumed by people who made the choice not to get vaccinated. Do you think we should be sharing more of that information besides on our little YouTube channel here tonight?
I think it would be helpful because, unless you are in the health system or somehow connected to it, it's very possible that you may not even know the full extent of what health systems are going through. And I think, Minnesota did something like that where they put out some information and really shared with people everything that was going on. It's hard to fathom unless you're there. So sharing that information, I think, is helpful.
Yeah. It just kind of comes back to, yes, people should have their personal choice, but we should all understand what risk you're putting everyone else at by making the choices you make. And, in this case, it seems pretty stark. Question from Patty Purcell. How do the death rates, whether vaccinated or unvaccinated, compare to influenza death rates?
Well, so influenza, is something that is going to cause a certain number of deaths every year in the population. And some of it just has to do with the fact that the vaccine isn't that great in the sense that it's not as effective in every group. Especially for older adults, the antibody level is not where it should be many times. And it, of course, changes from year to year. So the death rate, I think, in the earlier days of the pandemic was much higher than what we'd expected from flu. And part of it was attributable to, completely naive population, no supportive treatments, overwhelmed healthcare systems, and so on. Over time, with remdesivir and steroids and everything else that people have done, the death rate has really come down pretty dramatically. But it goes up and down based on where someone is and what resources they have and what access to treatments they have. So, I think we'd like it to be more like flu, but I don't think that we are there.
Yeah, I mean, ballpark, it looks like we're running at 500,000 deaths roughly annualized with
Astounding.
COVID.
Yeah,
And
it's
flu is maybe a tenth of that
right.
in a whole year.
Yeah. And last year we didn't have much of a flu season at all, which also is somewhat unexplained. Maybe the masks.
Masking. Yeah, right. Question from Gina Kazmersky. If you've had recent COVID but aren't vaccinated, are you as safe to be around as someone who's been boosted?
Well, so what we know is that the natural immunity to infection is pretty variable, and it depends to some extent by how many symptoms one has. So, in an asymptomatic individual who tests positive for COVID, yes, you'll have an immune response, but it won't be as robust as somebody who has had more severe symptoms. And so, because of that variability in the immune response, the recommendation is that even if you've had COVID, you should still get vaccinated. So, I think the answer to the question is yes, you have some immunity if you had infection, but you don't quite have that predictable immunity that you would expect from vaccination.
Warren Nesbitt wonders about whether COVID-19 or the Omicron variant could die out, noting that the Spanish flu died out after 1918 and 19. What was different about that? Had everyone just gotten it because we weren't able to defend ourselves in any other way, or what are the differences there?
I mean, I think the Spanish flu took just a tremendous toll, of course, on the world. It is, of course, possible that Omicron will die out too after it's sort of, laid waste to the entire globe, which is, of course, not something anyone wants to see. Pandemics have a way, I think, we've learned of being entirely unpredictable. I don't think, for instance, that many people saw Omicron coming until it was actually detected. I don't think we realized that there would be this degree of vaccine hesitancy and misinformation. I don't think we fully anticipated that monoclonal antibodies would not work as well against new variants. So there's a lot of unpredictability here still. And one of those factors might be that, yes, this could just die out on its own. And wouldn't that be great?
Patty Schinders wonders, what's your recommendation for patients that have had 2 doses of a vaccine and then a breakthrough case of COVID before they get the booster? Should they wait longer to get the booster or go in as soon as possible? What do you think?
There is no minimum time frame that one has to wait, but because they've recently had COVID, I think they should wait for at least the 10 days that it takes for people to not become contagious to others before they enter into a vaccination site. But beyond that, as long as they're feeling well, don't have high fever, and the ability to get there, that there's no reason that they can't get the booster.
Bill Scanlon wonders, in future years, might anti-influenza and anti-COVID vaccinations be given together? Will we see some kind of super vaccine develop that protects you from all these maladies?
Well, there's a lot of intense work going on in this area, and I wouldn't be surprised if we had some pretty amazing things coming down the pike here in the future. I mean, one aspect that people have been talking about is the possibility of nasal vaccines that are combinations that could be administered much easier than the injectable form. So I think we'll see a lot of advancements in the next few months in vaccines.
If I'm not getting my eligible kids vaccinated, what would you say to me? Because I think they won't really get that sick.
Well, I think that part of it is to determine whether you're a skeptic or whether you're a resistor. If you are a resistor, then there's probably no changing your mind. But if you're a skeptic, I think the things that have brought people around to considering that they should get their kids vaccinated is that, yes, the statistics will show that kids have mild disease, but your child isn't really a statistic. And even within those numbers, there are still plenty of kids that have landed in the hospital that have had the multi-inflammatory syndrome that is a consequence of COVID and in many children. And what parent wants to see that? And a well-tolerated, effective vaccine, if it offers an alternative, why wouldn't you take it?
Final question. There's been a lot of variation in how different states and regions have enacted COVID protocols, and even a lot of variation in how universities have established protocols for students, faculty, etc. Have we learned much about mortality rates and their variation across these regions in the US in particular, where we've got pretty good data and we've got quite a bit of variation in how people have responded? What do we know to date about COVID protocols and their efficacy?
I think the one for which the evidence is best is, of course, vaccination, where there's a clear drop in mortality in people who are vaccinated. I think for young, healthy adults, for example, in the school setting, I think there's good evidence that you can have high fidelity adoption of COVID protocols, which doesn't really include testing for many instances. It includes masking, it includes distancing, and it includes attention to ventilation. And with that, you can have a pretty safe school environment with very few cases. And if there are cases, with very little transmission, of course, in the setting of teachers being vaccinated and everyone wearing masks. So I think that there is reason for optimism, that it's the high fidelity piece that is tricky. If most of the people aren't doing what they're supposed to be doing and a few are, that isn't going to get you where you need to go. I think everybody has to row together for the COVID protocols to work.
And if teachers were vaccinated and boosted, are they at great risk in a classroom with students that maybe aren't distancing and aren't masking? And are the students relatively safe because they don't get severe cases? What are your thoughts on that?
Yeah, it's actually been, if you look at the outbreaks that have occurred, they typically stem from an unvaccinated individual, which was usually an adult in that case. And despite probably the best intentions, they were either reading to children or doing something else and took off their mask for greater projection. And so the kids all sitting in the front row then got tested for COVID and tested positive, and the ones that were sitting further away did not. And so I think the risk of transmission is really the distinction there is whether one is vaccinated or not. And those were not the days that the vaccine was approved for children. So the only party that could protect everyone was the adults.
Dr. Safdar, those are all the questions we have tonight. I'm sure we could come up with more, but you have been generous with your time. I know this has been a really difficult period. I wish you the happiest of holidays with your family. I'm sure you wish you had more time with them, but let's hope this Omicron variant kind of burns itself out quickly and maybe we can get to a more normal life again. And I look forward to seeing you in 2022. And I know our audience is really grateful to hear from you. We had a lot of people tune in tonight, and I'm not surprised.
Thank you very much. Thank you.
Well, thank you all for joining us this evening. The UW Now live stream will be back again on Tuesday, January 11th, where we'll hear from experts on the emerging financial ecosystem involving blockchain, cryptocurrencies, and non-fungible tokens, or NFTs. With luck, we might even be ready to have an NFT auction by that evening, so get your crypto coins ready. Thank you for joining us again. We are really grateful for the many experts who take their time on this show and answer your questions, and especially Dr. Safdar, who is now our most repeated guest, along with Noah Williams, who talks about the economy on a regular basis for us. Really appreciate the perspectives they share with our community. And I just want to wish you and your family and loved ones a safe and happy holiday season. We will see you on the other side of the new year. Congratulations to Badger Volleyball, NC2A champions, and let's go win the Vegas Bowl next week. On Wisconsin.
You can try, but you'll never stop a Badger. Because we Badgers are born with curious minds and endless heart. When we see a curve in the road, we speed up. When there are mask shortages for first responders, we make our own supply chain. When there's a world on pause, we sharpen our claws. Through thunder, fire, and pandemics, we'll keep going. Because after all, you can't stop. stop a badger.